Let's go ahead and get started. I'm really honored to introduce Dr. Doug Carlson today, one of our really just outstanding leaders in pediatric hospital medicine, and someone I've heard speak a few different times, and just I always learn so much from. Dr. Carlson's currently the chair of pediatrics at Southern Illinois University and the St. John's, Children's Hospital. And Dr. Carlson earned an undergraduate degree from Illinois Wesleyan University and then completed a medical degree at Southern Illinois in Springfield and residency at St. Louis Children's Hospitals. And then prior to going to Southern Illinois, he was at Washington University and St. Louis Children's Hospital for over 25 years, where he was Associate Chief of Medical Officer for Patient Safety and Clinical Quality, and he was also the Division Director for Pediatric Hospital Medicine. His research focuses on improving processes of care, and he's focused on improving access and outcomes in pediatric sedation. And he's recognized internationally for his work in pediatric sedation, certainly an expert and an outstanding exemplar of what pediatric hospitalists, I think, can do. Just the multifaceted, abilities of pediatric hospitalists all over the place: medical education, sedation, ER, hospital medicine. I think Dr. Carlson really has shown leadership in many areas, and really excited for him to talk to us today. And welcome. I will let you take the floor, and we're excited to learn from you. Thank you.
Well, thank you for that kind introduction. So I thought, I don't have a PowerPoint. I thought about putting one together, but then with the numbers and arrows and finances, be talking about this. And we'll go through about sort of my biases based on my experiences around this. Understand their biases. I don't think they're incorrect biases, but how I see the world from a financial impact. And through my career as things grown, I've had to understand about how finances drive my goals for clinical development, meeting the needs of patients, helping people come up with the arguments, particularly around how to develop sedation programs and other things. And so I'll just walk quickly through my journey of gaining financial acumen and understanding how money flows and how big institutions make decisions around the things that are important to us as hospitalists. So I really began that journey. I started my career as an emergency physician. I do admit it proudly that I am board certified in 2 specialties and never did a fellowship. I practiced pathway into emergency medicine, and then I did it all over again in hospital medicine. So I feel lucky about the time it did just show this. I think saw what those opportunities were. I think my strength as I reflect on my career was seeing opportunities and then advocating for myself to be part of that, or listening carefully to others as they came to me and said, "Hey, Doug, we want you to solve this problem because of what you've done." Then always listening carefully. When they've come to me, we've gotten to know, because it just didn't make a lot of sense, but being careful about that. And I first looked, when I was looking at things, we reported on, I mentioned even at the leadership, this recent Emerging Leader Conference at the AAP, something that's been important to me as we're looking at starting new programs in hospital medicine. There are 4 things that I largely look at when we're starting a new program. Is there a clinical need? Why hospitalist? I have made career hospital medicine has built its power, or doing things of where there's gaps and no one else is doing it. Sometimes no one else wants to do it, or many times people didn't know that it needed to be done. So it's doing all those things. But our hospitalists, is there a clinical need? If you think there is, or somebody's coming to you, usually it is, but define that. The second part of that was to look at who were the best people doing. Was it hospitalists? Was it nurse practitioners? Was it just the specialist to do it? Going to work nights in the PICU because they don't want to work nights. That's not really a winner. It's doing that. And then the third thing I said, I used to have 3, and you'll laugh when I get to the 4th. The third is important. Does it bring career satisfaction to the people that are doing it? Does the things that we do? Does sedation add to the things you're doing? Does doing a call center? Does caring for newborns? Does it add to the things you do? And if the answer to all 3 of those, then get to that. The part that I learned was that I now add on, it has to be financially viable. Someone has to pay for it. thought, what's a good, if these are good ideas, we'll find a way. But then it's part of that about how figuring out how that is. So here's some of my biases. I don't have an MBA. We'll have a question period. If it comes up, we can go into more detail, but I would say, is an MBA a good idea? Depends on what your goals are. It's complicated, but if your goals are, yes. There's never a time in my career when I said, oh, I need to get an MBA. It's part of the lack of knowledge, part of my transitions, part of anything else. Now, if I had one, there may have been opportunities available that weren't available, but largely I've been very happy working in 2 institutions and having basically about 7 different jobs, all of which have led to the increases in what I know about finances and how to fund things. The first time that when I really became an accidental hospitalist was when I saw an opportunity at a community hospital about 10 miles west of St. Louis Children's Hospital, in a little more affluent area with a little better payer mix than in the downtown location of St. Louis Children's Hospital. And I was asked, sort of arm twisted in a way, but eventually said an enthusiastic yes, not a reluctant yes, to begin a program where a nursery service had just moved from a downtown location out there. So they went from like 800 deliveries a year to 3,000 deliveries a year. That was the biggest impetus, was covering 24 hours a day a nursery service with hospitalists or neonatal colleagues covered during the day and responded for emergencies, but we covered at night. And then with that, because my background in emergency medicine, started a small emergency department, and then only seeing about I can't even remember. It was just about 8,000 kids a year, and then a small inpatient unit, combining all 3 together, 1 person at a time, combining all those things. At the time, that was good idea. Were we the right people? Did it build satisfaction? Grew the group in hospital medicine? Well, I established a group based on that. We didn't even know that was in 1996, the same year that the term was coined. But looking at that, I was not involved in the finances so much. It was between the hospital and Washington University saying, I was negotiating what the staffing was. So the finances were more really saying, I need 6 people to cover this 24 hours a day, and they need to be paid a fair wage. That was my financial acumen around that. But we made sure that we were not understaffing it, that we were looking at this. And then the people that I reported to did the financial calculations, worked with the hospital, and the hospital paid for that service. Then, as we sort of were growing over time, we built a hospital division of nearly 50 people looking at each different thing, and it was understanding how the operations worked. And I've been in 2 different types of situations, although it is important for you, one thing I say is to understand what the financial structure, and that's usually the same as the organizational structure of the organizations you work in for your positions. Both Washington University and BJC Healthcare, St. Louis Children's Hospital, and where I am now, we are a practice plan, which is part of the medical school. So I have always been an employee of the medical school, both at Washington University and now at Southern Illinois University. Our hospitals are independent, not-for-profit hospitals. Now in a Catholic system, small Catholic system, and BJC in a slightly larger non-denominational system that has its pros and cons around that, negotiating with that. But I will say, I just finished a 4-month journey about looking at a new position, and it's taught me a lot. It's not going to happen. We can talk about disappointment and things. I'm happy staying where I am. I've got a great job, but it did give me a long look into how another university works. And that university, I'll even say it was St. Louis University, was being recruited and to look at a vice dean of clinical affairs. And in that case, the SSM health system had bought the practice plan a year ago. So SLU Care used to be owned by the university, and the model that I was used to in Washington University and Southern Illinois University, but it was now the physicians were a practice plan within several practice plans within SSM for for St. Louis area. They have, it's a $6 billion system, I think 30 some hospitals across 6 states. So a much bigger part, and that's a smaller cog. And then it was working with making sure that they still had the academic mission. It's a reasonable model. I was excited about potentially joining it, but it did give me an insight into how the money flowed and how it was different than what I was used to. All the decisions of money was decided by the system. And it was either do it or don't do it. But sometimes you had to do it because it was the system that decided what the practice plan was going to do. So that was a much different model. It had its positives. So it did mean that, whereas that other part is when you look at where the systems that you're working in, who do you report to in the sense of eventually to the boards? Not that you, an individual, have to worry about that, but these are two separate examples, and there's other models. The system that I'm used to in mine is where I work within a practice plan that reports to the dean, who reports to the president of the university, who reports to the board of Southern Illinois University. When I was at Washington University as a clinician, my job, I reported to the chair, who reported to the dean, who reported to the chancellor, who reported to the board of Washington University. But the clinical things that I did were on our hospital side. So I had to have influence and roles, medical director roles, other things, so that when I'm working in the hospital, it is reporting to a CMO or president of the hospital or chief nursing officer, and that it's convincing the hospital in order to pay for those things. So you have to understand where it's coming. You also need to sort of, even when you're in a large children's hospital, it can be different, because you hear, if you ask someone if they work in a freestanding children's hospital, they're going to say yes. If it's a hospital with 4 walls, and within those walls, they take care of kids. That's actually not the definition by the Children's Hospital Association. The definition of a freestanding children's hospital, and there's only 20 or so in the country, there's quite a few more that have their own buildings, but it's whether your report through the board of the children's hospital, and the children's hospital board is the end. And so when I was at St. Louis Children's Hospital, we were a freestanding children's hospital early in my career, before I even cared anything about it, and then became part of a system, BJC system. So the Children's Hospital Board reported to the BJC system board. Not a bad thing, but it did give much less autonomy. And I think that around that, and so I will talk a little bit about the differences between a children's hospital and being within a children's hospital within a larger hospital, let alone the system, and sort of doing this. But understanding who has the dollars and where they flow from, where you're trying to get the support to do the things that you're doing. Remember, good ideas will largely win, but you need to then understand how to talk the language that they want to talk in order to make those financially viable. So where does money come from in hospitals? It largely comes from volume on the pediatric side. It comes from having kids in the hospital, or having kids get ancillary services on an outpatient side. MRIs, labs, radiologies, EEGs, all those things matter. And so when I tell a story, it's about we're going to concentrate on the hospital-based services, but it goes for all the hospital-based services, is that if I say I need, if we look at, I'm pretty good, we can get into it if you're looking at other things around how you decide how many hospitals you need to staff a unit. But regardless of that, when you make that argument, you do first make the argument that we need X number. And we'll make this the most simple at first. A 24-hour-a-day service, regardless how busy it is, if you need to be there, you need to be having close to 5.5 or 6 people. I shudder when I hear about this. When you hear 4 people are working, that's just not sustainable. Now, I've seen systems where it's sustainable when you round during the day and you're sleeping in your own bed at night, and you're rarely called in, and you live in a community that's important to you. Those can be sustainable over time, but not largely. So as we're talking about this, it's understanding what hospitalists do. Many times the first thing administrators will do is say, well, look at your RVUs and your revenue for what you do. They're not even looking at what they do as far as having patients in those beds. And remember, when a child is admitted to the hospital, the ratio is often 10 to 1 or even a little bit more what the hospital is able to bill for those services versus what you are able to bill for those services. And that doesn't even include the ancillaries. You hear a lot about DRGs on the adult side. Those do come into play, but even on the adult side, they get paid for when somebody is admitted based on their diagnosis. And then the goal for them is to spend as little money as possible, get them out so that they're paid a lump sum so they use less of that lump sum. And we have some of that in pediatrics, but largely when a child is admitted to the hospital then benefits for doing the things we do, even when they're unnecessary. It's still better to have short lengths of stay for better outcomes of our patients. And it's also better for hospitals to be as small as they can be to meet a population demand. So length of stay is important. The hospitals do way better by being efficient about taking care of a patient as quickly as possible, discharging them to safe environments with the follow-up they need, and getting that next patient into that bed. Because it's when you need new beds. I remember 20 years ago talking to a hospital administrator where they were talking about it cost $1 million a bed to build a bed in a pediatric hospital. I've heard figures of a high single millions up to $10 million. This is a lot. So it's a lot to do that. So they want you to be as efficient as possible. But do remember, it's driving those volumes. So the more kids that you can get into the hospital, the more kids as a referral center, the more kids that you can do those things. That's where the money comes from. You're not going to go to the hospital manager and say, look at what is the downstream revenue implication of a pediatric hospitals. But there are, we do know from outside agencies. I think I threw it away, but accidentally as I was purging my desk. But a pediatric hospital, a general pediatrician on a national scale in an integrated healthcare practice. So their tests, her prescriptions, everything that they do stays in the healthcare system, including referrals to other specialists or surgeons, and the hospital care has an impact of about $1.4 million in a positive margin for what they are doing. And it goes up, neurosurgeons do a lot better. When you see these things, you can understand why they get paid obscene amounts of money. But a pediatrician is at $1.4 million. And a hospitalist is going to have that impact too. So it may be a little less than that because a general pediatrician is ordering more things and they control a panel of several thousand patients. You're reacting to that. But it is when you're negotiating these things, it's about improving patient care. It is about meeting unmet need, and that's what we're really good at, and then working with others. And as I said, I don't have an MBA, but now I have. I had to learn quickly. I became chair of pediatrics, and that's not just because of a chair of pediatrics. And chairs of pediatrics are different too. But we now have 60 physicians, about 30 nurse practitioners, and about 290 total employees that are on the payroll of the Department of Pediatrics. And so I'm responsible for that. For the billings and collections on the outpatient side, negotiating with the hospital for support, working with the dean, because it's not just pediatrics, it's surgery, it's OB, the other things we're doing. Our university here is that the women's and children's services are with one hospital, which is where I am, and then most of the other services are at a competing hospital just down the street in a different system. But SIU is the providers of women and children's services without much other competition. So we have to say, do you want this? How do you support this? Now, the way we do that is understanding our impact. They're not going to tell you what it is, but it's saying, if you want this service, here's the number of people I need to do it. Here's the amount. Because of our experience, we know that if they work hard, they're likely to generate that. And then saying the hospital, if you want this service, then you're gonna have to pay a service fee to provide that service. A couple of lessons. They will use the word they're not the enemy. But when anybody uses the word subsidy, just say, no, no, no. This is not a subsidy, because subsidy implies that they're giving you money to make you whole. Everything that you negotiate is the money you deserve to run, that you need to run the service, and you deserve to have longitudinal activities around that. Couple of things about how we determine salaries, and then what we go with the hospital and the flows, is that there are three major indexes for pediatric salaries. Well, actually, all specialties. we do look at the academic parts of all three. They are MGMA, they are the AAMC, and they are the AAAP. Just a little word about that is that you will hear your chairs if you're an academic institution. I certainly heard this when I was at Washington University, and we participated in now the AAAP. It is absolutely the most accurate of the salary ranges, but in a very niche way. So the AAP is the Association of Academic Administrators in Pediatrics, the people that are the administrators for the chairs. They are measuring I mean, most of the university-based children's hospitals participate in this. But it is the lowest because it is a self-fulfilling group. So that if you're asking an instructor, I remember when I was originally a hospitalist and we said, we need raises in hospital medicine. It's crazy how little money that we pay our hospitalists. And they pulled out this and they said, well, Doug, we had instructors at Washington University. Instructors at Washington University make X, and that's at the 50th percentile. And I told my chair, we are the only instructors in hospital medicine in the Midwest. So of course, we're at the 50th percentile. And so it is, so be careful about that. And I think the chairs are beginning to understand as the new study came out from the Academy of Science and Engineering and Medicine about how salaries are artificially low in pediatrics, that I have argued, I've had pushback, have artificially kept salaries low because you have a group which is close, all giving data in, and we all want to pay at the 50th percentile. There is no doing this. Now, I love living in Springfield. I grew up in Decatur. I went to medical school here. That's why I came back. It's a town of just over 100,000 people. Cost of living is cheap. The schools are great, and so it's a good place to live. But it's, as you can imagine, it's hard to get people to come here. It was hard even when I lived in St. Louis. So when I first got here, I said we pay that in a positive way because it was more than we were paying at Washington University. But it was because in trying to get people in, we do need to pay at a higher level. We use MGMA or AAMC. MGMA academic is usually a little bit higher than the AAMC. So we target at close to the 75th percentile on the MGMA part of this. The reason I tell you this is just as you're sort of getting involved in some of these things, you cannot go online and find this data. It is not secret, but you can't go online and find that. And I think as you're in leadership positions, you're going to have a hard time. You're just saying, help me understand. It's you're in groups where you're in charge of hiring people. It's going to be important for you to know what those standards are. Those are the three areas to sort of triangulate what other people in your region should be making around that. Then your chair or your dean will say, we pay at the 50th percentile. Or sometimes they say, we'll pay at the 25th percentile. Then, and if you do take some time, I've not made it the way all through. I think it'll be important reading for all of you for the new about developing pediatric workforce and specialties, which just came out a couple weeks ago from the NASA, which was commissioned partly by, actually the AMSODEC commissioned it, and the ABP and a few others commissioned it. And it's a really good study looking at where we need to go to maintain a workforce in pediatric subspecialty care and in pediatrics in general, because we're at a crisis point. There's a lot there. Let me open up to questions. I mean, I don't want to confuse you about things, but thought I would open it up to questions about money flow, learning about finances, how to understand finances to get to the goals of what you want to do in your careers and your jobs.
Hi, I can start. My name is Parvati. I'm a peds hospitalist. Fortunately or unfortunately, I'm also trained in peds ID. And all of what you're saying.
That was not an economic decision.
No, clearly not.
Well, 6 years or 5 years of fellowship, and MGMA says you make less money than a general pediatrician, but you did it for the right reasons.
I want to say so. But the thing is, me and my husband unfortunately do the same thing. So I'm giving you this background just to kind of put some
Yeah.
context because it resonates the conversation, and I appreciate you sharing all of this kind of big picture because we are in the process of looking and understanding our own value. As part of the conversation, what I meant to say is I primarily do hospitalist, mostly also to not compete for my husband's job, but also to help with the money because being a hospitalist certainly greases the wheel a little better, so to speak. But it's just understanding our value when we go to search for a new job or just negotiate with our current employers, right? We get paid at the 10th percentile, I believe, for and I think on the AAMC, I think is where the benchmark was when we had like interviewed and kind of took our position where we were at, which is decent money. But then when you think about it, the value that we bring, not just as a hospitalist, but also as a subspecialist, that is 2 out of 3 bodies in the whole state of New Mexico. It is like, how do you even appreciate that sort of like what you bring? Mostly because, right, we are like notorious as pediatricians to not be able to advocate for what we are worth. Like I have no clue still how to say how much I'm worth. Like somebody asked me, what would be an accepting salary for you? I'm like, okay, I don't know. Let's start somewhere. Give me some benchmarks and then we'll talk from there. No question, but just mostly
No, I
comments,
think
yes.
no, there's actually a lot there in sort of understanding how money flows in this. Let's take the ID part of this first. There are some changes that need to be made. There should be no specialty where you do 3 years of fellowship, including hospital medicine, and your average income is less than general pediatrics. General pediatrics needs to be paid more than they're doing now. So that should be added on there. And I think as you're looking at this, you are stuck in a market around what you're doing. So you don't have complete power. You can't just say, I deserve more and necessarily get more, but you can go in negotiating stance of looking at things about understanding how money flows into those things. Both of these things, for example, but then also looking where they earmark. Yeah, Albuquerque. I actually was offered a job, not the University of New Mexico. I almost left academic medicine. I was offered a service line director of Presbyterian health in Albuquerque. So I know Albuquerque, pretty well. At the time, I'm glad I didn't because I've been leaving academic medicine and my career would have been completely different. But we were enamored by Albuquerque. But I know enough that New Mexico is one of the poorest states in the country. About a $2 million population. That's enough to support pediatrics specialties, but not a broad range of this. And there is obviously, you could benefit from some competition between the University of New Mexico and what's happening at Presbyterian, although Presbyterian was taking more niche services at the time and probably doing that. But I think that in both these, and hospital medicine and ID are largely the same. If I look at the billings of my infectious disease specialist, they're the lowest in the department. Lowest by a long way. They are really busy, and they may, by the way we generate the RVUs conversion factors, literally bring in less than $20,000 a year by traditional parts of this. That can be used like, okay, what should I get you to? And I don't know the AAMC numbers, but I do know what the number, the assistant professor for infectious disease and the MGMA is about $180,000. Mm-hmm. And I assume that I'm not going to ask you what you're making, but I think understanding with this, but then when you're going to the hospital for support, when I go to the hospital for support, I have to solve a problem. And you have to sort of, are you at a place where they're using you to help solve a problem in the way that you want to be helped? Because what infectious disease does is that I know that they are my busiest subspecialty in the call to the hospital. Night call's not that bad. They're not getting woken in the hospital and have to come in and do an LP. But on a Saturday or Sunday, there's more consults in our NICU or inpatient area PICU than any other specialty. Our pulmonologists aren't that busy. Others, gastroenterologists, we work in a system where we admit everything to the hospital medicine service, with the exception of hematology oncology. But of our specialists for the hospital-based service, and you can't with antibiotic stewardship and those things, those are all negotiating value. Pediatricians are taken advantage of And we're taken advantage of largely because we are a female predominant specialty. I believe that because we are trying to do things around our lives where we give away some negotiating stance. And I will say, I was the interim chief medical officer for a number of years, for 1 year, a couple of years ago here. In emergency, I stepped in for your remain chair of pediatrics. And one thing I found with negotiating with adult doctors was that the other part of this, we love in pediatrics being associated with the things we're associated with, often in tertiary care medical centers, often with medical schools, often with those things. But we had negotiations. I was part of the negotiations on the dean's team where somebody would come in and say, you need a new interventional cardiologist. And we'd say, yes, we do. We've got support from the hospital because that brings in a lot of money for this. And we're going to pay you a pretty high rate for interventional cardiology and academic side. The numbers were really high, and they would say, yeah, I do. I enjoy the research I've done. I enjoy teaching. I enjoy working with fellows. But just down the street, the independent practice, they're going to offer me $100,000 more. We don't have that ability within pediatrics, because we are stuck within those areas. So I think it's a long journey, but is advocating for those things about how you advocate for the value that brings to the children's hospital or within the children's hospital. And for us, for ID, because I do this with our ID, we just went and said, we have a great infectious disease specialist, and she was officially doing antibiotic stewardship on the pediatric side. They pay the adult infectious disease to be the director of antibiotic stewardship, but that person says, I'm not doing pediatrics. This person had fit in this. And I said, she needs a title. I actually found other ways to pay her for this. They wouldn't give her a title because they figured once I gave her a title, then they were going to come into this. But that's also the value, is understanding the value to what they're doing. So both of these, you have to say, you need coverage 24 hours a day for the call service for ID in hospital or not. It doesn't depend. You can work either way, our hospitals are not in the hospital, but that brings value in the quality, the safety, the throughput. And we order a lot of tests, appropriately order a lot of tests that brings in the revenue to support that.
Thank you. Just as a closing statement for that, I have traditionally always based myself in hospital medicine, mostly just to protect myself. And I think my first division chief did that. He's like, you're based in hospital medicine. That's what your salary is going to be based off. Because when I left Hershey and I came to UNM, I was brought on as a hospitalist, and as an associate, I was given 193 something, but as an associate here in Peds ID full time, the gentleman was making like 170.
Yeah.
It was just based on the fact of which division I was in. And so I think it's always just worked out that I think I've blanketed myself, that just base myself in hospital medicine just to kind of, even that is like lowballing us, right? Like that is still like saying 10th percentile of like the least of the scales that you get to. But but I appreciate it. Thank you.
And I do think, so I have heard the new concept has come up, and I've heard chairs talk about this recently, that they have gone to their hospital partners and saying, that hospital medicine is a baseline. It's an initial one, that no specialist should make less than a hospitalist. That probably does in the end help hospitalists a little bit if it brings everybody up to that. It doesn't help hospitalists, but helps at least to say there's a baseline in adolescent medicine, baseline in endocrinology. There's like six or seven specialties where you make less than a general pediatrician the things that I know on the hospitalist, and the ones you can. Generally, the ones you can think of on a national scale make less than hospitalists at the same rank, with or without fellowships.
I have a question.
Sure.
And I'm wondering if you could, my name's Kate Donowitz. I'm a pediatric hospitalist, and I'm actually, I just transitioned institutions and have a new role. In addition to my hospital medicine work, I'm doing integrative medicine at UVA. And so actually, this is really timely for me, because I think one of the things that I'm realizing I need to understand is that flow of money through the department and through we have one other colleague who does integrative medicine, but it seems to be something that if, you ask the questions that you said of, is there a clinical need? Who are the best people to do it? Does it bring career satisfaction? All of those things. It seems to be, at least within our community, a very desired area for growth. And I find myself in the position of like really needing to understand that flow of money. I could you be a little bit more granular when you say like, as somebody who has zero background, and nor do I really desire to like go get an MBA, what are some practical, what meetings should I be trying to attend? What documents should I be trying to get my hands on as somebody who's trying to understand the flow of money through a division or department in order to potentially grow an area that interests me?
Yeah, I think you're attacking it the right way. To say what is the need, what we're doing, what's the benefit to the hospital, what's the benefit of the community around this. Integrative medicine, you may not have as much benefit to the hospital, and I may not understand as much, but it's sort of what you are doing, but the things that you are doing, how it improves outcomes of kids, how it's doing this. You may be a little more working on these sort of improved outcomes. Shouldn't we support this? We'll spend less money on insurance and other things. But there are ways. I didn't talk about how insurance and savings can come into this. We will eventually get into cost savings and shared risk around those things. Although I've been hearing the terms shared risk and cost accountability for 2 decades, and I'm not sure we're that much closer in pediatrics. Although I think there'll be a tipping point. And that tipping point, maybe the tipping point is farther away, but coming. I think you asked a question about how you learn about these things. For the most part, for me, it was having people that I trusted, that were mentors or colleagues that I would go and ask the questions around this. And for the most part, I think it fits with anybody who's doing things. If you ask questions, hey, tell me about this, what you do, you better understand it. I want to understand more about this. And I think whoever even your bosses are, say, hey, I think that this is not recognized in the way from salary. What do you need? What can I help with? Or what do you know? How is this determined? What are the things that we can do around in showing the things that you're doing that are bringing value? So remember, value is outcomes over cost, and you can improve value by improving outcomes. It's best when you lower cost too, but it is really both of those. Sometimes we think of value just as the cost that it provides. There's no easy answer here. Everybody's a little bit differently. Integrative medicine is not an area that I've analyzed for my own personal needs for looking at the cost benefit analysis of how you negotiate for those things. But it is finding the people that understand the money. Occasionally you'll get a roadblock like, why do you need to know? Occasionally the hospital, if you sort of see, the paradigm of a used car salesman, they're not going to give you all the information they have because there's less bargaining power. And I found that a little bit in my current situation around this, but you just keep asking questions. And I've got really good financial people on my side that now report to me, but that hasn't always been the case, of asking the questions about how money flows and other things. And I think that asking, talk about in a learning environment around those, getting together with your faculty and asking this question in your institution, how do we fund the things that are important? And understanding where the money is coming from. We just expanded pediatrics because there was an insurance battle. And we benefited from that because one of the non-SIU practice plans pulled out of Blue Cross Blue Shield thinking they would win in a minute. We have 4 positions funded by Blue Cross Blue Shield to increase access in pediatrics, 2 in primary care and 2 in other areas. So there are, depending on your markets. The whole idea about how cooperation between your practice and funders, and many organizations where I was looking at SSM is an insurance company too. So that's a case where if this going in on the insurance arm and saying, we're going to save you money because of these kids will need, we're going to overall save you money. But we do need to do a few things, of which then the hospital makes money, or whoever's providing those ancillary services on. So everything you do spend, you keep as profit within the system, but more importantly, say, here's the money we're saving you by keeping kids out of the hospital, not having these expensive things. And that's a little harder in the current paradigm in pediatrics because we say we want to add value. We want value-driven care. But for the most part, as I said, the thing that drives hospitals, which in pediatrics, is having kids in the hospital. The other part of this is that I am lucky enough that neonatology reports through me, both financially and through the structure of things. And I'll tell the joke. I think it'll come off the right way. Is that as a current chair of pediatrics, where the NICU reports to me, He said, I hope we find a cure for prematurity. I just don't want it to happen until after I retire. Because also then understanding where the money is coming from, because you work in an institution, an integrated, where you're part of that. There are places that may not be overpaid, but there is some socialism more in pediatrics than other areas. The NICU, we found out that the hospital's reluctant to tell us the number. I don't think they slipped. They realized they could tell us this number, and it would be power for both of us as we were looking at expanding both pediatric service, our perinatal center. This was about getting a new MFM physician. The MFM physician says costs us money, but the MFM physician sees mothers who then deliver premature babies who get admitted to the NICU, and we found out that the average on admission to our NICU, the profit is $200,000. And that pays for a lot of things. They were fighting us for a new MFM specialist who was an SIU colleague. And we wanted $350,000 in support. And we showed them that we will expand what we are doing and so we only needed 2. So finally they were pushing back. And as soon as they said that, they looked at each other and said, we'll get back to you. But how do you get into that? So it's also understanding the broad base of the other things that you do, because you can't be trapped in, I do this and I bill for this and I collect this. I'd be glad to, or I can send out my email. I'm glad to continue this conversation with anybody on here and be a resource. And I've always offered that when I've given talks and say, you can send me an email. And I got a lot of things I do, but emails are my squirrels, and I tend to be focused on that. So I actually like it. It breaks up my day to answer questions and keep dialogues going. So please do not hesitate to send me an email if there's other things that come out, or clarification, or other things that come up once we're done with this conversation.
Hi, I'm Michelle Essig. I'm one of the hospitalists in Children's LA. I think the 4 things that you had mentioned really resonated with us. We are undergoing a lot of model of care change right now, or we're trying to.
Yeah.
And, we're coming across right now, I think, in terms of our model of care, we have a lot of co-management services with other medical specialties. So, in addition to the surgical specialties, but so this includes like cardiology, liver transplant, all of that stuff. In those 4 things, we're finding more and more that the career satisfaction piece of it is one of the biggest barriers. And can you speak to how maybe you kind of come across this in the past, where the need was there, and sometimes it is hospitalists that I think can provide a lot of that institutional knowledge, that throughput, all of that. But a lot of our faculty, especially the new ones that are coming in, are just really not satisfied with doing a lot of that cares.
Yeah. So co-management can be difficult. It can be enough in all environments, but in an environment where you're actually doing co-management, a couple of things. One of the things I eventually kept getting to know too in my old institution, and he was a personal friend. He kept asking. They were looking about how to get better care over at night times on the general surgery floor. And I said, come to me with a plan of where we're providing 24-hour-a-day care. I can make that work. I will not ever be able to find a way. I said, but isn't that what you want to do? Take care of kids in the hospital? Yes, but we don't want to work all nights. And I need to we work enough nights as hospitalists that if you come to me like sedation, say it's a daytime service or it's other things, we're much more likely to get to yes than that. And then it's really sort of what co-management is. And co-management is really being involved in the care and generally being responsible for parts of the care. Many co-management models, you become a highly paid resident. where you are really just writing orders. And it's worse than being a resident because they really don't care about your academic and intellectual growth. They don't have to test, is it important for my growth around this? So I think it is really looking at you have to understand, why is it not satisfying it? Is it the relationship, which is well-meaning people can get into the things where I'm in charge, you're here, but I'm really in charge around co-management and consultation. And I think that when when the surgeons ask us to, we always say, you can consult us, but what that doesn't mean is that we'll manage the patients. We'll see them every day. We'll make sure everything goes well. The hospitalist is there, our residence is there, but we're not taking over pain control. We're not taking over post-surgical management, and we're not writing the discharge summary and the discharge orders. And in our system of things, but it was hard. And I know that Dave Rappaport at DuPont has written about this for a lot. That would be a good resource around it, because their children's hospital in Wilmington, Delaware, is a big, it's a full service children's hospital, but they tend to have way more surgery than a population of patients. So they had to get in this business, and they've talked about rules of engagement and other things. But then also, if you are decide to do this, there's not that much billing left, because many of the bundled charges in surgery are not there. So you just have to say that we will work hard to collect what we can, but what we can collect for this doesn't matter. So you need to say, whatever the service is, we need 5 people to do this. Or if it's a daytime service, you're rounding once a day, 2.5, whatever. Figure out what it is that's livable around those times. Around this. And I think that's where the second question is that if the people that are asking you to do this, or if you ask them the same questions, they're going to say, is there a clinical need? That's absolute. Where it fails for you starts at the second one. Are you the right people to do it? Would it be nurse practitioners? Is it who else, or PAs? Who else is it? That may be the answer. Although it's harder to get PAs and NPs to work at night than it is than pediatricians. But the third is that we can start this, but it's not adding satisfaction to overall. And it can be neutral for some. It can even be negative for a few, but it has to be at least a little positive, or it will fail over time. And I found that. And then the financial part, you say, is it financially viable to do this? We need to hire 4 people at this salary, or it's not going to work. That's why I found that those 4 pillars as you're doing this really help. And it helps teach other people, because they don't think about your satisfaction. They think, you have a skill which will be valuable to me. Why won't you do this?
Thanks. I think that was so pertinent and definitely addressed my question. Thank you.
Okay. I'm glad to walk through barriers too, just trying to convince. Because part of this, in the sense of leadership, we're doing this, is trying to convince other people, like teaching them, rather than just saying no. No is, we talk about you're saying yes to committees and other things. No is a complete sentence, but sometimes, and no is a complete sentence, like, no, I'm not doing that. But to build that trust over time, you have to explain why it's a no. It's like, I just don't want to do it. I do say that we have made, especially by doing the things that other people don't want to do. So sometimes we have to get to yes, but we have to do it on our own terms. Any last questions or anything? I've enjoyed the hour. Hopefully you found this helpful.
I appreciate you leaving the doors open for us to reach back out.
Yeah, no, I'll be glad to. Do you have my email? You can write it down, dcarlson28, and we'll get everybody, I think, where I can set it up. It's dcarlson28 at siumed.edu.
Yeah, I'll send it to everyone for sure.
Okay.
Yeah. I have a question.
Sure.
When you talked about the difference between, say, revenue as a group of physicians rounding and seeing patients in the hospital, it can be extremely variable if you're a hospital medicine group that does some procedures, that does some sedations, that does this, we may never be able to compete with the NICU, with the ICU or anything like that from an RVU perspective. But are there other places where we can use data information to show our value and specifics? I don't know what you think about collecting data like case mix index and you know, showing kind of this is the impact we're making, that is, you know, then maybe bringing in that revenue to the hospital, in that maybe we're not doing the procedures, but without us the stuff's just not getting done. And so any advice on either CMI or other data that can help a hospital medicine program show its value?
Yeah, I think all those are important. And the CM of what the kids that you're seeing, how you're adding value, who you're seeing, what you're seeing, the 24-hour a day coverage of what we're doing. And I actually am a fan of triangulating data to show your story. For example, as we look at, we just did a thing of all the physicians practice plan, but we'll talk about pediatrics, particularly hospital-based pediatrician, hospital-based pediatricians. So critical care, hospital medicine, and NICU, and we vary their salaries based on what national benchmarks are. But as we're going to the hospital, they have this idea that we're just sitting around not doing anything. We're the value. And what I found is that I'm a little worried when somebody says the administration says our RVUs are not high enough around this, because you're providing a 24-hour a day service, and we have decided to only be able to provide billing once a day. Time-based billing may change that a little bit, but it's not going to change it drastically. One reason the NICU is so because they have critical care, they have bundled billing for 24 hours a day. They 30 years ago figured out how to get way higher RVUs for units of work for taking care of babies than we do with older kids. But I do think of telling that story, and I think for the most part, you know, hospitals are going through financial crises, and they may be no. But I also think that if you're getting data and asking questions, you're going to help most administrators. Most administrators are good people. They have a goal of making the hospital, whether it's a for-profit hospital or a not-for-profit hospital, they have to make a margin or they'll lose their jobs. But they're still interested in providing care to kids. And you need to tell that story. And the data is important. There's not one specific piece of data, but the case mix index, RVUs based on national standards. You can find RVUs for your specialty for national standards. And for hospitals, they're not that high. They're way lower than a neonatologist. But what you can say is you say, I need another hospitalist in order to cover this service, because one person a day no longer does it. I need to add, which is a really good satisfactory in hospital medicine. The good news is when you add a hospitalist, it's a daytime hour. So it really helps things a lot. And what you say is that they said, well, they're seeing an average of 10 patients a day. They said, well, we've got data to show that's the national average. Our case mix index is high. So that shows you that the kids that we're seeing are sicker than that. And then using RVU when it's appropriate to say, we are at nationally the RVUs for 50th percentile, which means we're providing a service 24 hours a day, but we are not underperforming. We're performing as this, and you're paying us at the 10th percentile, or whatever. So it is looking at that. And then also for hospital medicine and hospital-based things, it's understanding what is a full-time clinical FTE, either academic or non-academic. And there's papers out there, and I think largely I've used 1800, and it's come to different things. And actually AmsterdX's doing an exercise, and they're using hospital medicine, and the surveys are showing like 1800 hours as the clinical part of an academic FTE. So you can say that we need more people because we're here 24 hours a day and we're working 2,300 hours. That's not sustainable. It's not a sustainable market. And even if our RVUs are below the national average, you need someone here to attend deliveries or be available for consults in the emergency room or emergencies. So even though we don't meet the national standards, the basis is 24 hours a day, and that takes 5.5 people with some administration, 6 people. So all that data. And because I think data is important in understanding this. And as I'm telling you, so I just sent the dean, as I'm looking, we have a pediatric, we share some pediatric nephrologists with Washington University. I had a pediatric nephrologist contact me a few months ago, says, I'm moving to Springfield, Illinois. I don't have funding for that. So today I sent an email to the dean I have to convince the dean first and the people on the SIU side about why we need that, even though in the end, her revenue is not going to be that high. I now need subsidy, but I'm making an argument the value that it's going to bring. Now, if I convince the dean, we will go together to the hospital and say we need this support for a pediatric nephrologist about what it's going to do for the community of having better access for pediatric nephrology around those things. So and I didn't have a line item for our pending needs. If somebody leaves, I have a line item, I can fill that position right away. So I have to sell that argument. And I think it's the same thing, selling why a pediatric nephrologist is necessary to meet the population needs because of and there I'm going to look at the propensity for who's leaving the market, who's doing these things. So all those data, I'm a big believer in data. I worry when when administrators say, here's one piece of data that you're failing at.
Thank you.
Learn how to tell
everyone.
your story. Negotiating, to get money, you have to understand where the money's coming from. Then it's telling your story about the things, and always make it patient-centric. You're important. Your health and well-being are important, but if their health and well-being as making it patient-centric. It's okay to say this is not sustainable. The work that we're doing, no matter how much we want to do it, is not sustainable. Because it's all evenings a week. I didn't leave emergency medicine on purpose, but there you have a specialty of which is all sucky hours. At least in hospital medicine, as we add new services, for the most part, they're daytime services. Because I've seen places where you have 4 hospitals during the day, 2 in the evenings, and 1 at night. The emergency room can't do that. So we have some things going for us, but I appreciate your joining me today. I had fun.
Thank you so much. Really appreciate everyone's input and questions, and thank you for an outstanding session. I will share Doug's email with everyone.
Great.
All right. Have a wonderful rest of your day. Thank
I
you.
will.
Cheers. Thank you, Carly.
Thank you so much.